Well, welcome to this video, and I'm so pleased today to welcome Dr. Tina Pierce. Tina, welcome and thank you so much for coming.
Thank you very much for inviting me, John. Very
Not at all.
privileged.
Now, we've talked about lots of interesting things, chatting just before the recording and last week. Maybe start off with a bit of background about yourself, Tina, if you don't mind.
Yes, of course. So I qualified a long time ago in 1983 from Guy's Hospital Medical School, and I thought at that time that I really wanted to be a GP. So I trained in general practice, and I worked in general practice for 7 years. But I actually didn't find it as satisfying as I had hoped because the appointment times were too short. And to actually get to know a patient and find out what's really going on behind and causing the disease or the symptoms that they're presenting with, there just wasn't enough time. So I found it wasn't very satisfactory, really. And at the same time, I was very interested in women's health, and I had was doing a lot of contraceptive clinics and really enjoying those. And then in 1994, I was asked if I would run the services for East Surrey for contraception, and so I said yes. And there was no office or secretary or anything, and I had to put all of that in place, develop the services, which was great fun. And then I was asked in 2002 if I would run Mid Surrey as well, so I said yes. And then I was asked if I would run the whole of Surrey contraceptive services in 2012, and I said yes. Oh no, in 2005 actually, so I said yes. And I did that, and I had a fantastic team. And we used to work very closely with the Director of Public Health. I would meet the Director of Public Health. So for 24 years, I met the Director of Public Health every 3 months, and we would discuss all the teenage pregnancies and the termination rates and the different wards within the county where there were areas of deprivation and where we needed to really have a presence and help the population. And then it was down to me. So we would decide the policies together, the director and I, and then it was down to me to put it in place, and make it happen, train the staff, get the money, find the locations to open the clinics. And it was a very successful department. And by 2012, we had brought down the teenage pregnancy rate to the lowest level for over 20 years, which was really quite something. So we're very proud of that. I had a fantastic team. And it was really going very well. And then in 2017, they closed loads of clinics and sort of just decimated the service. So they closed 36 weekly contraceptive clinics in Surrey. So from 20 different sites, and we went from 20 sites to 3. And Surrey's a big county. It was very, very difficult then to run a very good comprehensive service from just 3 sites. And a lot of young girls couldn't get there, etc., which was really disappointing. So I left that service in 2017. And in the meantime, I had also been developing myself as a menopause specialist. And I started to work at the Chelsea and Westminster Hospital. I got my menopause specialist qualification. And then I was working there until the first lockdown, when they then closed that clinic. And then I decided I would just work privately. So I see a lot of women for menopause now as a menopause specialist. But I have another string to my bow, which is that in 2016, my youngest daughter became extremely unwell. And she had been chronically not great all her life, and we had never quite got to the bottom of it. So she had terrible eczema from 3 months old. She was always pale. In photographs of my 3 children, there would be this little ghost, which was little Jessie. She just looked like a ghost. She always had a sort of distended tummy, IBS type sort of picture. And she was always cheerful, always brilliant, never complained, but obviously wasn't terribly well. And we just kept being told it's eczema, it's eczema, it's eczema, and she'll grow out of it. And unfortunately, she didn't grow out of it. And when she was 13, it sort of got worse. And then when she was 16 and went to college, it became even worse when she caught swine flu. And then she had a terrible migraine for 4 weeks and really became very much like a chronic fatigue syndrome ME patient. And tried to press on and she did her A levels, and she got, anyway, bless her heart, she was very uncomplaining but not very well at all. And then in 2016, she was a student nurse on the COVID wards, and she was fed up of feeling chronically ill, so she decided to bullet a lot of superfoods and do lots of exercise and try and go on a sort of health kick. So she was superfooding and blitzing all this stuff, which was actually very high in histamine, this food. And she was drinking it by the gallon, and she became iller and iller and iller. So it was like she had terrible flu, but her eczema was awful. I mean, it was just her arms, her neck, it just absolutely erupted everywhere. When she turned her head, her skin would break and tear. It was that bad. It was absolutely awful. So she was bleeding onto her sheets. She was bleeding onto all her clothes. It was just terrible. But she was also feeling faint and dizzy. So she had POTS symptoms with tachycardia. She had diarrhea, bloating, abdominal pain. She would wake up in the night with nausea and have to run to the bathroom thinking she was going to be sick. She was covered in a tiny little histamine rash, which was all over her body and very itchy, as well as the eczema. She was bloating like a balloon with lots of fluid retention. She had a migraine that again lasted for 4 weeks. She went for 7 days without any sleep at all. She had total insomnia. Even though she was exhausted, she couldn't sleep, not even for a second. It was terrible. And that's because her histamine was so high. Anyway, and then she had the migraine. She had just so many symptoms, 30 symptoms, affecting lots of different systems. And she rang me up, and she burst into tears, which isn't like her at all. And she said, "I can hardly open my eyes, and I can't, and my mouth is all cracked, and I can't even really drink anything." And I said, "Right, I'm coming round to get you." So I jumped in the car, picked her up, brought her home, and she had dermatographism, where you could just write on her skin and it would leave, your signature for 20 minutes. She looked absolutely terrible. And we sat her down, and I got her a straw and water with a straw so that she could try and drink and everything. And my husband made the diagnosis, actually, because I said to her, "Look, you haven't eaten anything all day. I'm going to make you some organic carrots, organic potato, and I had some organic minced lamb." And I said, "This will be very safe, let's try and feed you." So she had some carrots, she was okay. She had some potatoes, she was okay. She put a teaspoon of the minced lamb in her mouth, and within seconds she flushed like we'd just set off a bomb in her head. She just went absolutely bright red like a Venetia beacon. And she started to sort of feel even worse. And my husband, bless him, said, "Oh, it's like she's allergic to everything. It's like histamine." And when he said histamine, then it started to click for me, because 9 years before, a friend who was a chiropractor had said to me, "Do you know anything about histamine intolerance?" And I said, "No." And she said, "Well, I think maybe your Jessie's got it." And she gave me a little piece of paper with this definition of histamine intolerance on it. And I went on to Google, and in those days, and this was 9 years before 2016, there was nothing on the internet about histamine intolerance. So I couldn't really sort of progress my research, and I just filed it to the back of my head. And then when my husband said she's got high histamine levels, I suddenly thought she's got histamine intolerance. And then when I looked again in 2016, there was more information. So I went through all of the bits that I could find on it and see all the symptoms, and she fitted all the symptoms were what she was expressing. And so then we were on a quest to find out how to treat it, because there wasn't very much on the internet about treating it. So I was using my little knowledge and common sense that I had, was like, well, let's give her some antihistamines. So we bought some vexapenidine, but we just gave her one a day, which isn't sufficient at all when you've got such high levels, toxic levels of histamine. And I also tried to find out what was high histamine food and what wasn't, and it wasn't very straightforward to find it. Anyway, cut a long story short, we couldn't find any doctors who could help us, because nobody seemed to know anything about it, except one wonderful man called Professor Vic Kular, who is a urogynecologist. And I came across him by accident through a colleague at the Chelsea and Westminster Menopause Clinic. And I managed to speak to him, and I said, all the list of all the symptoms that she had, and I was very worried about her and she looked terrible. And I said to him, I think she's got histamine intolerance. And he said, I think you're absolutely right. And it was such a relief to have somebody say, you're barking up the right tree. And then he said to me, right, what have you done for her? And I said, well, we're trying a low histamine diet. We're trying antihistamines. He said, what are you giving her? I said, fexofenadine, 120 milligrams once a day. He said, oh, no, go up to 180 and give it to her 4 times a day. And that's the maximum safe dose that the European Society of Dermatology has said it's maximum safe dose. So we did that. He said also we need to give her a type 2 antihistamine. So we got some famotidine, 20 milligrams twice a day. Take that. And then he said, right, and then, ring me up in a week's time, let me know how she's doing. Well, as soon as we started giving her the type 1 and type 2 antihistamine in bigger doses, her skin started to calm down. She didn't have the dermatographism anymore. She started to, over a 2-week period, she lost 1/2 stone in weight as she literally peed it out of her tissues. She was going to the toilet every 15 minutes, just getting rid of fluid from all this inflammation that she had been in. She could then fit into her jeans again and things which she couldn't with before she'd become so bloated. But it took 4 weeks for her to start looking like herself again, for her face to go down and so on. And then I was on a quest really to find out more and more about this condition. And when I discovered that's when I discovered mast cell activation syndrome, because Professor Koula said histamine is usually associated with abnormal mast cells. And then he started teaching me really about the condition, which was fantastic. He was a great mentor. And I started reading as much as I could about it. And then, of course, when you see something, you can't unsee it. And so I had this all in my mind, and then I would be seeing a patient in my contraception clinic who was coming for some contraception. I'd be taking a history from them to see which contraceptives they could use safely and could choose from. And then they would say, well, I've got IBS, or I've always had chronic headaches, or I get funny rashes or whatever. And I would be very interested in asking them more and more information about that, and building up a picture of this sort of chronic inflammation in various different systems, giving various different symptoms of different severity at different times. And then I would say to the patients, I think I might know what you have. And most of them, John, would burst into tears because they had maybe decades of chronic ill health with no clue as to what was happening to them or why, and no understanding of how to improve their condition. And then I would just give them some basic lifestyle advice about avoiding high histamine foods, and various vitamins and minerals to take which would support their system, and things like vitamin C, which is an antihistamine, a natural antihistamine, and also how to take a type 1 and maybe a type 2 antihistamine. And they would come back and they would say, I feel so much better. I can't tell you, all my diarrhea has stopped, or my tummy isn't bloated anymore, or whatever. And it was very, very satisfying. And I was literally making this accidental diagnosis in 3 or 4 patients a week, because actually it's very common. Professor Molderings from Bonn University, who is probably the most knowledgeable man on the planet about mast cell activation, he's done research into it with his fellows, and they reckon it's 17 to 20% of the population that have abnormal mast cells that are overactive and can be, affected when they should just be ignoring certain chemical stimulants, etc. But they can't.
So it's a real iceberg condition then.
Absolutely. And so every single doctor is seeing these cases every day in their clinical practice. But because it's not taught in medical schools and it's not really in any of the books, it's not something that they're aware of. So they are struggling in the dark trying to help these patients. when actually, if they have this knowledge, you can then start to understand the mechanism, the biology that's going on, and therefore how to help and treat these patients. And it's very satisfying. It's very, very satisfying to do that. And it's not the doctor's fault that they don't know about it, because they haven't been taught. However, I think when somebody has seen somebody like me and they go back to their doctor and they say, this is what I've got and I'm feeling much better on the treatment, I think then I would hope that that doctor would have the curiosity to actually find out more about it, but more and more doctors are now. So when in 2016, when I started off, apart from Professor Vitkula, I didn't know any other doctors in the UK. There were some probably, but I just didn't know of them. But now, I know of several cardiologists who talk about mast cell activation syndrome and recognize it in their patients, several gastroenterologists who see it in their patients. And so there's more and more of us who are helping these people, which is great. So that's sort of background, really. And then, of course, long COVID came along.
I want to go on to long COVID, but you've tweaked my curiosity on the histamine. I mean, histamine's basically a fairly simple chemical. I mean, are people intolerant to histamine, or is it that particular foods cause the mast cells to release their own endogenous histamine?
Yes, exactly. So what tends to happen is, and it seems to be a double whammy in a lot of these patients. So there are two conditions. There's a condition called histamine intolerance, and that's not a very good name for it, really. That group of patients, if we do their genetics, we can see, and if we do blood tests, we can see that they don't make enough diamine oxidase. And diamine oxidase is an enzyme that metabolizes histamine out of your food. So it's in the stomach, and your body realizes that whilst histamine is good to have, you don't want to have too much of it. Too much of it is troublesome. And so the body recognizes that, and it has diamine oxidase in the stomach to reduce the amount of histamine in the food, so less is absorbed and doesn't push your histamine levels too high. But and it's also a little bit in the bloodstream, so it can be measured. The diamine oxidase can be measured. And most of my patients who have MCAS are diamine oxidase deficient, and they don't make enough. So it's a bit of a double whammy, They don't make enough diamine oxidase to reduce the histamine absorption, so they have excessive histamine absorption from their food. And they also have mast cells that release too much histamine too easily. And so they end up with these high levels that the body can't really cope with and clear out very quickly.
And do those two things tend to go together, the lack of the diamine oxidase to get rid of the histamine, so they're not getting rid of what there is there already, and the mast cell activation syndrome, the MCAS, they tend to go together?
Well, it's interesting. In the sort of literature, it says that histamine intolerance is the incidence is 3-5% of the population. But we know that the mast cell activation syndrome, as defined by Professor Molderings in Bonn University, is about 17 to 20% of the population. Now, on a lot of my patients, we do some nutrigenomics on them. We look at their genetics, and we look at their methylation cycle and so on. And one of the things we do is look at their histamine metabolism. And I must say that it is very seldom that my patients who I suspect MCAS in have a normal diamine oxidase production. Most of them have got a deficiency in the diamine oxidase.
Spooky.
As well.
You wouldn't think. There's no obvious reason in my mind why they're related.
No.
Unless the genes are close together or something like that.
Maybe, because we do know that there are apparently 50 mutations in the KIT genes have been identified that can be caused.
What are the KIT genes, Tina?
The KIT genes are the ones that are giving the code, if you like, for mast cells, for the white blood cells. So they've identified 50 different mutations in those that can result in mast cell activation, and probably some people have different combinations of each of those, and some people might just have a few, and some people might be unlucky and have more than a few. It tends to run in families, so it's genetic for sure. And so there'll always be a family history of IBS or chronic fatigue in some family member, or chronic headaches, or urticaria, psoriasis, rosacea, eczema. So yes, or they'll have somebody with joint aches and pains, fibromyalgia. You see, fibromyalgia is a symptom, isn't it? And these patients are complaining of all of these things. POTS, 80% are hypermobile. 80% have hypermobility. 80% of patients with MCAS are female, and 30% will suffer with interstitial cystitis. And that's why Professor Vic Kular is aware of the condition, because he treats interstitial cystitis as a urogynecologist. That's his particular area of interest.
Wow, that is a lot of fascinating information. I want to go back to that, but let's just bring people up to speed a bit on mast cells. So my simplistic idea is mast cells are a kind of white blood cell, maybe derived from basophil type cells, but they don't circulate. They sit in the tissues and they store histamine. And then when we want an inflammatory response, which of course is good, the heat, pain, redness, swelling will increase the circulation to an area, get us more nutrients, get us more blood supply, help the healing process. Then when we want that, then these cells degranulate and release the histamine. So am I right, roughly right in saying that mast cells are histamine storage units? Is that?
Absolutely, but unfortunately they store a whole lot more. They have 1,000 different cytokines in them. So they've got a lot of chemical potential and ability biologically, and so you're absolutely right. They are generally in the tissues. They are interstitial, and they are everywhere where our body is in contact with the outside environment. So they are all under our skin. And when you understand and think about this, then you can see why the symptoms manifest in the way they do. So they are underneath the skin, they are lining the nasal passages, they're lining the sinuses, they're lining our nasopharynx everywhere. They line the lungs, they line the gut from mouth to bottom, all the way down. They line the urogenital tract. And they are, I always think of them as like the bouncers in a club. And they're just inside the door, and they really want to stop the undesirables coming in. Okay, but in patients with MCAS, these bouncers are a bit overzealous, and they start reacting and want to fight with anything that comes their way. And there are some things they should just ignore and let in, and they don't. So they overreact, and when they react, they release some or all or different combinations of these cytokines. And we don't even know what all of them do, but 1,000 have been identified thus far.
And 1,000 cytokines have been identified altogether, or 1,000 cytokines from MAF?
Yes. No, 1,000 cytokines have been identified. I think Bonn University did that work.
I think of cytokines as cell-to-cell hormones. It's a chemical released by one cell that can have a kinetic, an effect on another cell.
Yes, and then there are chemokines. They release 350 chemokines, which are little messengers, and these ones take little messengers to the other mast cells. So if there was an assault in one area, the chemokines could be released, and they rush over to other mast cells that are a bit dopey and tell them to react as well and join in. So they create a big army.
Which is why we can sometimes get a systemic histamine release, which is
exactly. So if somebody's mast cells, also mast cells line the nerves, and histamine is a neurotransmitter, and they are also present in the stomach. They release acid in the stomach. The chromographine cells. So they've got a very important role to play in cognitive functions, circadian rhythm. This is histamine. Histamine has an important role to play, but we don't want too much of it. We don't want too much. We want it just appropriately where it's needed at that time, and then to be got rid of. But in these poor patients, it hangs around in vast quantities, plus some of the other cytokines, which can cause bruising. I mean, my daughter, when she was super sick, she was bruising so easily. She just had to touch her skin and she would leave her fingerprints in bruises. And patients often, it's a question I ask my patients, do you bruise easily? Oh, yes, covered in bruises, easily. Don't even remember knocking myself and I've got a great big bruise on my leg. Itch of mosquito bites, big bruise develops, you know. So they get heparin is released. Heparin is one of the cytokines, and that can cause bruising. And you've got elastase 2 is released, and that causes membranes to break down. Also, there are some that cause are clotting factors that actually make blood clot. So you've got bleeding, you've got clotting, you've got inflammation, and so on. In mast cell activation syndrome, generally there is always inflammation. There may or may not be allergic type reactions, including anaphylaxis, but there may not be. And there can be dystrophisms. And dystrophisms are formations of new tissue. And they may or may not be there. So they could be things like cysts in the breast, in the pancreas, and are often associated with it. And they think that's a dystrophism from the mast cells. It can also be poor wound healing. So it can affect the healing process and other mechanisms, normal mechanisms in the body. It could be, what else? So it could be bleeding and also, as I say, clotting problems. So people can have a combination of these things. Maybe they only have the inflammation, or they can have the inflammation and allergy type symptoms or whatever. And depending on where the stimulation has the mast cells have released the chemicals will depend on the symptoms they get. So if it's in the lung, they will get asthmatic type symptoms. And a lot of my patients tell me they've been given inhalers which don't work, because actually it's not constriction of the airways that's causing the problem. It's inflammation. So the mechanism is different. So what you need is the anti-inflammatories, the antihistamines, to reduce that activity, not anti-inflammatories. Anti-inflammatories make them worse.
Right. So going through there's a wide range of symptoms here. So we've got potential blood clotting, bruises, chronic inflammation that can express itself in different systems, such as irritable bowel syndrome, maybe cardiovascular, maybe respiratory, inflammatory symptoms, rashes, urticaria, which is like those itchy rashes, isn't it?
Hives. Sometimes they get hives.
Can like spread over the surface of the skin.
Yes, big sort of swollen areas.
And intensely itchy, presumably.
Very uncomfortable. Sometimes it can just be from their clothes rubbing. They have very super sensitive, so it can be where they've got if they've got waisted trousers or something, when they open their trousers, they've got this great big wheel all around their middle where their clothes have touched them.
Going on with the symptoms, headaches, the swelling, the edema. A variation over time seems to be a key feature. I mean, you seem to be describing an incredibly wide spectrum of clinical manifestations here. What is it that specifically draws your mind to the mast cell activation syndrome diagnosis?
That's a very good question. It's really, you start to recognize patterns, inflammatory patterns, and also what else could be explaining it, So if you've got somebody, once you've seen a few patients like this, you start to really just recognize the patterns. Often they have sensitive skin and cut labels out of their clothes. Not all, but most of them do. Often they have extremely sensitive sense
because
of
the label
smell.
rubs on the back of the neck or something.
Yes. But often they have a very strong sense of smell. So it's like their senses are really heightened, and really strong sense of smell, a bit like a sort of greyhound, And then they often don't like bright lights and loud noises, because they're intolerant to this
the nerves have been sensitized by the adjacent mast cell deactivation, presumably.
Yes, presumably, and so this is it's worth saying it's a very new area that's being described and explored, and the research is in its infancy, and we're hoping that as biological tests that become more available to measure some of the cytokines that are released, it's going to make it easier for us to maybe see patterns of these cytokines are released to give this symptom, and this treatment is best for that patient, therefore, etc., etc. There's a huge overlap, and the symptoms will vary time to time, person to person, and within the same person at different times. So it can be confusing, and often patients, they accept their normal, their symptoms as just, it's just me, I'm always intolerant to that bit of food, or I always go bright red when I have a glass of wine, and they just accept it as sort of, if they're not too bad, it's just, that's what I am. But generally with this condition, as their mast cells are activated more and more, they become more and more sensitive in a stepwise kind of fashion. So with my daughter, she was, her mast cells were obviously unhappy from the word go. Well, not from the word go. Until she was 3-4 months old, she was fine. 6 months old, it was then that she developed it. And then she became much worse when she had swine flu at the age of 16. So that infection, she never quite recovered her health to what it was before the swine flu. She was sick for 6 weeks, and then she just did not get back to, she was worse, she was more like an ME kind of picture. And then she had chicken pox as an adult when she was like 19, and she was really ill. And again, she just did not get back. She became worse and worse and worse, her general health, and it was only really the crisis that made us realize exactly what it was and come to the diagnosis that we could then really help her properly. And when we did her diamine oxidase, for example, so normal diamine oxidase is 30 to 200. The labs will say that it's unlikely that you have histamine intolerance if it's over 10, but I disagree with that. I think if the normal is 30 to 200, then anything below 30 is not quite enough. And with my daughter, for example, when we took her diamine oxidase in her crisis, it was undetectable. As fast as her body was making it was gone. Yeah. So it was undetectable. And when we did it 6 months later, it was 23.5. Wow. So if she had just had a 23.5, somebody would say you haven't got mast cell activation syndrome and histamine intolerance, but she does. But we got it to that level by working really hard on having no histamine foods whatsoever, and being, taking antihistamines and everything else. And she managed to get it up to 23.5, but that's still not normal.
When people get the cutaneous manifestations, is it normally the same patch of skin on the same part of the body that's affected every time? Or can they get manifestations in different parts of the body?
It can be that they always get one particular patch or one particular place. Presumably there are a few more mast cells there than everywhere else, maybe, I don't know. But sometimes it can be just, honestly, it's almost like anything goes. Sometimes it can be different patches, different areas, and they can't really work out why it's suddenly appearing here, whether it was before it was there. So it's not easy to completely understand exactly what is going on, but a lot of people, if they are judged clinically under what we call consensus 1, they will be told you haven't got mast cell activation syndrome, there's nothing we can do for you, and actually I think that's too hard, and that we should be following, I'm more in line with consensus 2, which is that actually you don't have to have a blood test to prove that they've got MCAS. You just need the clinical picture, and then it's reasonable, if you have reasonable suspicion to think that they have MCAS, to try some of the medications and simple measures that we put in place to try a trial of treatment, if you like, and if they respond well, then they have MCAS.
I want to come on to the consensus in a bit more detail in a minute, but if we can just talk about, there's a lot of people watching now who think, oh, just a minute. So obviously, if you suspect this, go to your own healthcare provider and ask them that, and ask for these tests. That's quite reasonable. But in terms of just treatment principles, can we just kind of sketch out what treatments are available? Diet-wise, is it just a matter of working out what's good and bad for you, or are the particular usual flyers of foods that cause problems quite regularly?
Yeah, there's a very good website called
Yeah.
whatthebleepcanieat.com, which is a great name. And if you go on there, you can put in the histamine. So you can get a list of histamine-free foods that have no histamine in them at all, and low histamine foods, and that comes to about 200. And so you can have a varied and healthy diet from these 200. So you're having a low histamine diet. And there are certain things that are very high in histamine that you want to avoid as much as possible. So things like tomatoes, avocados, spinach, bananas, a lot of the things that are very convenient to eat and people eat a
And you
lot
would
of.
normally think of as being healthy.
And they
Yeah,
are.
indeed. Yeah.
They are for
Yeah.
most people. But for about 20% of the population, they will cause a problem. And so it's very, I think it's a good advice to have a look at the list and see where you are. So gluten is very high in histamine. Tea and coffee, green tea, alcohol, and chocolate are double whammies because they're very high in histamine and they also block diamine oxidase production. So you don't really want to be taking those. And I think also processed foods are very high in histamine. No surprise there. And leftovers, anything that's been reheated or been sitting around for a while, when the bacteria grow on the surface of the food, even if it's a low histamine food, bacteria will be on it and they convert histidine to histamine. And so they will make it a high histamine food which was what happened with the mincemeat. So lamb doesn't have high histamine, but minced it does because it's got a big surface area, lots of bacteria on it. So when she put that in her mouth, she suddenly gave herself even more of the mast cells just sort of
Makes
went
perfect
crazy.
sense. And do some people become symptomatic? Do they get flare-ups, even if it's a low histamine food that they just happen to be particularly sensitive or allergic to?
Yeah, it all depends, I think, where they are in their histamine bucket. People talk about a histamine bucket. So if they have been really good with their diet and they haven't been near chemicals that have stimulated histamine and the histamine levels are very low, they will probably get away with eating something that is a little bit higher in histamine. Because if you imagine, if it has to be over a certain threshold to cause symptoms and they're really low and then they eat it, it just goes up a bit, but they're still not high enough to cause symptoms. Whereas if they're trundling along just underneath the threshold and they even just have a tiny bit of something that's histamine, it goes right up. So sometimes they could eat that food and get away with it. And other times they won't be able to because of where they are with their bucket. You see, so that can confuse people. They can think, oh, I could eat that yesterday and now today I can't.
Understandable.
So,
So dietary modifications.
Yeah.
Vitamin
Yes.
C and other vitamins. Is vitamin D a factor?
Yes, actually, yes. So just prior to that, you can actually take diamine oxidase
Oh, I
before
didn't know
your
you could
meals.
take it. Wow. Oh, right.
Yes, and there are DAO supplements, and it's very helpful in most people for them to take that before any meal because it will help their deficiency. So you can buy DAO capsules and tablets. There are various different ones on the market, which you can a couple of those 5-10 minutes before the meal. That can be very helpful too. And pea shoots, people can grow pea shoots on their windowsills and have 8 or 9 little pea shoots, lovely, leaves before they eat their meal, 10 minutes before their meal, and that will have a reasonable amount of diamine oxidase in it. So they can do that. So that's the sort of basic thing. The other thing is, it's probably a very good idea for them to have a paleo-ketogenic diet, certainly ketogenic diet, so that they are not having too much in the way of carbohydrates, but they are having what we call an anti-inflammatory diet. So it's helping their bodies in that way. And then we go on to what do we do for them. So with the supplements, vitamin C is fantastically helpful because it has antibiotic type properties. It's an antihistamine, and it's a bit anti-inflammatory. So it's really good for them to have a natural antihistamine in the form of vitamin C. So slow release vitamin C is a good idea. Otherwise, you have to drink it all day long. And then vitamin D is also very important, and with some K2. And then we usually like to give them, ask them to take magnesium. So these are things to support the mitochondria, because they get mitochondrial dysfunction, and therefore their energy production isn't very good. And mitochondria are fascinating little organelles. They're absolutely amazing. There are, often thousands in each cell. They're making ATP. We actually produce 70 to 80 kilograms of ATP every single day.
I didn't know that. Do we really?
Isn't that amazing?
You must be cycling at one heck of a rate.
Exactly. As soon as it's made, it's gone.
The energy currency of the cell.
Yes, but there's such a huge demand for it that we have to make 70 to 80 kilograms a day just to stay alive.
Wow.
Isn't that fascinating? If we took all of our mitochondria out, apparently, and put them in a pile, it would be 32% of our body weight.
I had no idea.
Yes,
this is so interesting.
And our heart has got the most, and our heart.
Yeah, I would have known that, I think, because of the liver, of course.
And use up so much energy, absolutely. So mitochondrial function is super, super important. And when patients who have ME say they have post-exertion malaise, and they do something and then they're absolutely wiped out, it's because their mitochondria are just not up to the task. They're dysfunctional from everything that's going on with the high histamine, etc., and these other cytokines we don't.
I get that all the time. People say I'm fine, but I get disproportionately tired after a small amount of exercise, and that varies from time to time.
Yes, and we think it's all connected, all with the mitochondria and so on. So you have to support the mitochondria, and that's the energy production system of the body. Needs to be firing on all cylinders. And so we give them the vitamin C, vitamin D, magnesium, K2, then coenzyme Q10.
Right. I've never understood that.
That's really good for your.
And that's basically a nutrient, isn't it? You get it in food.
Yes, you do, and you also your body makes it a bit too. So you don't want to interfere with coenzyme Q10 production. That's very important. And then L-carnitine, which is an amine that's useful for the mitochondria, and iodine. Very important to have iodine. Now, iodine. Most of us we have insufficient iodine. Generally in our diets and in us, and it's so important for a number of reasons. Very important for all our glands. So for the thyroid, the breast, the prostate.
Well, everyone knows the thyroid, but why do these other glands need it?
Yes, well, I'm not quite sure, to be honest.
They do.
But they need, now whether it's because of the mitochondria that needs the iodine, I'm not sure. But so iodine is something terribly important, and so we like the patients to have iodine, and we ask them to take 2 or 3 drops of iodine, Lugol's 15%, in some water before they go to bed. And that helps to also ensure that the upper gut is sterile, because our upper gut should be sterile.
Does it really? Iodine disinfects the upper gut? Wow.
Yes,
I've never thought of that. So, it makes perfect sense, because iodine kills everything.
It does, yeah. And you take 2 drops of water every
that's
night.
Probably what, 4 milligrams, something like that, of iodine.
Yes, it is a small amount, yeah.
But way higher than the national recommended guidelines. Yeah,
probably, but needed. And if you don't need it, what do you just want to take it off?
If you live in Japan or South Korea, or you like seaweed, you're going to get way more than that from your natural diet anyway. It's just that in the UK we don't eat much seaweed. And surprisingly, fish contain surprisingly little iodine. It's the seaweeds. Yes. We really need to eat more seaweed.
Yeah, but as you say, if they have that in their diet and it's not doing them any harm, to have 2 drops at night in some water is going to be absolutely safe and fine. And so much of the inflammation comes from the gut. We've got so many mast cells in our gut, and when they start to get upset, then you are in for trouble, really, and then it spreads to other areas. So we really have to spend a lot of time trying to get the gut right.
I've been talking to Professor Dalgleish, oncologist, lately.
Yes.
And he was saying that, probably, you can't say all, but in so many cancers, chronic inflammation is a big causative factor. And that chronic inflammation can come from bacterial breakdown products from the gut, causing chronic inflammation, different parts of the body. I know most of it's broken down when it goes through the liver, of course, but maybe not all. And so
Yeah.
that's a plausible mechanism, because I've talked to other doctors who believe, and I've got good evidence to say that regular iodine can reduce some types of cancer. That fits together.
I'm not surprised. Yeah, I'm not surprised, because we also think there are theories, aren't there, about mitochondrial health, and if you have mitochondrial dysfunction, then you are more likely to get cancerous cells. With cancer cells will have mitochondrial dysfunction. So there's a whole load. It's a really complex picture. But in my simple mind, I like to think of it like, if we get inflammation in the gut, then we're in trouble, because you get leaky gut.
Do you? Right, I didn't know. Right, yeah, so gut inflammation can cause leaky gut, which means that proteins rather than amino acids can get into the circulation.
Exactly. Wow. Exactly. So it's a perfect storm. So the lining of the gut is only one cell thick. And if you've got all these mast cells sitting underneath it, and you've got things coming in the diet, etc., that are making it them active, and they cause swelling, then the inflammation of the lining of the gut is going to make crevices and cracks form, and that's leaky gut. So then you're in big trouble, because you've got semi-digested proteins, you've got semi-digested food. You've also, because our diet isn't like the caveman's diet, but it's got sugar and dairy and grains in it, you've got bacteria there. The upper gut is supposed to be sterile. In caveman, it was sterile. The first 20 feet of our gut was just purely sterile, there for digestion and absorption. Now, with the sugars and the dairy product, the bacteria that come in are not killed necessarily by the acid of the stomach. And
they're given lots of nice sugars to eat.
Yes, they multiply, and they produce gases, and they ferment and make alcohol, and then they pass through these crevices into the body. And of course, that's going to stimulate your mast cells even more, because they shouldn't be coming in. And that's going to set up inflammation in all sorts of places in the body. And so we've got to get the gut right, and we've got to start with the diet and do a ketogenic, low histamine diet for those who have histamine issues. But for all of us, we should be, I think, ketogenic, sugar.
I think it's fair to say everyone should, unless you're actually acutely hypoglycemic, or you are severely malnourished. Sugars and sugars are also maybe good for children with infections, or rehydration salts and things like that. But apart from that, I mean, for me, I would be better on a completely zero sugar diet, and to massively cut down on carbs, and preferably eliminate all refined carbohydrates. I'm trying. I'm just not very good at it. But
well, absolutely, because you know why it's difficult, because they're addictive.
Totally addictive.
They're so
and it gives you that instant hit. So you get up in the morning and you want toast and marmalade, and you get that instant sugar hit. And you think you can face the day as long as you've had a good cup of tea as well, and it's just that instant gratification. But if you eat other foods, it just you feel better. It just takes a little bit longer.
So if you had an egg, for example, we used to go to work on an egg, didn't we? And the children, I mean, I wish the children could go to school on an egg, because that protein would sustain them till lunchtime. So they wouldn't get that dip of their blood sugar mid-morning. They wouldn't want then more sugary snacks, which will do exactly the same thing.
And the fat keeps you full for longer as well.
Absolutely. So it would be So anyway, so we've got to So what we do.
So I've just got a geeky question. The iodine will only sterilise the first 20 feet is probably about the first 60% or so of the gut, the first, just over half. It won't reduce the microbiome in the colon.
No, it won't at all. It'll be sorted out in the small intestine. Your microbiome should stay in the large intestine. Because we want
microbiome, but we want it in the right place.
We want it in the right place. We don't want it in the other bit. So we're confusing everything with our poor diets, and so we're trying to encourage people to get back to organic, natural, in season, eating as our sort of primitive, ancestors did. I say primitive; they'd probably be insulted if they heard me say that. But our ancestors, and how actually our bodies have evolved to want to eat. And sugar is addictive for a reason, because when there was cave woman and caveman in the autumn, late summer, autumn, and all the fruits came, they would start eating the fruit. And the sugar would switch on an addictive gene that we have, apparently, which would make them want to eat and gorge on it, and then they would get a bit fatter, which would help them go through the winter. But after 2 weeks of not eating, of all the all the fruits gone from the trees, and the berries and everything have gone, after 2 weeks, you lose that addiction. The addiction gene switches off. But in modern society, it never switches off.
We keep feeding it Mars bars.
Yeah, we keep feeding it whatever, chocolate. Oh, I'll just have one of those. And we see it as a reward. Oh, I'll just finish this horrible lot of emails, and then I'll go and have a piece of chocolate and a cup of tea. Or I'll have a biscuit and so we're constantly rewarding ourselves.
You've just described me perfectly, Tina. I feel really self-conscious now.
Oh, no. But if you just manage not to have sugar for 2 weeks,
you can break the addiction.
Yeah, the gene switches off.
Makes sense.
Yeah.
So we're designed to eat seasonally. So poor caveman and cavewoman would be sitting there in cold turkey for a few days when the fruit all went. But after that, they'd be fine. Yeah.
And they were a little bit fatter, so they got
exactly
through the lean winter.
And that would increase female fertility as well, because they put a bit of weight on. And yeah,
exactly. Yeah, so you can sort of see. So we talk all about that. And obviously you want good probiotics. You want to get good probiotics into the gut, which we've heard lots of discussion about. But then you want to bring down the histamine, and we generally try, and it's the treatment is a lot of trial and error. You have to be very patient, and you have to methodically go through different treatment regimes for the patient, regimens, because what works in one person doesn't necessarily work in another. But when you find something that works, it's a eureka moment. It can be amazing. So, for example, we would basically try type 1 antihistamines to block the type 1 receptors. So those would be loratadine, cetirizine, fexofenadine, basically.
These are all over-the-counter medications. Yeah.
All over the counter. The top dose of fexofenadine in this country has to have a prescription for 180 milligrams. But for 120, you can buy it over the counter. So we encourage people to try each one for a couple of weeks, but not to take one a day. On the packets of loratadine, it will say one daily. And actually, they only last for about 4 or 5 hours, the effect in the body. So it's not long enough. So you have to do one, say 3 times a day for a couple of weeks, and see if you feel that that's worked for you. And if you think, gosh, yes, it really, my rashes have gone and I'm feeling better, and my chest is a bit better and so on, then carry on with that one. You don't need to try any others. But if you get to the end of 2 weeks and you think, did that help or didn't it help? It means it didn't. Because if it does help, And in which case, then try cetirizine and do the same thing. And if that doesn't help, try fexofenadine. What works in one person doesn't necessarily work in another. And then, so having done that, you then want to add in, so we do it in a very low and slow way. You add in, say, famotidine, a type 2 antihistamine. So
the type 2 affect more histamine receptors, do they? Just remind me.
So they're mostly in the gut. And so it can be incredibly life-changing for their gut symptoms. But in some people, it won't work at all. It doesn't make any difference, in which case there's no point in taking it. So for a lot of people who say they have acid reflux, when they take famotidine or nizatidine, the acid reflux goes straight away. That's the type 2s.
Yeah.
Yes, the type 2. But I've also had patients who have had chronic diarrhea, urgent chronic diarrhea, 7-8 times a day for decades. Can you imagine how exhausting that is? They have to know exactly where all the toilets are on their way to work, because they have to literally toilet hop, And I had one lady like that, and I gave her the famotidine, and after 1 day of taking famotidine, her diarrhea stopped for the first time in 20 years.
Is the type 2 available over the counter as well? You have to get those prescribed?
In this country, we have to get it by prescription. And then after that, we try mast cell stabilizers. So there's 3 that we can use in particular. You can buy quercetin over the counter, which is a mast cell stabilizer. So that's an easy one for people to try. And you can take 500 milligrams 3 times a day, if you wanted to, or twice a day. And then but the ones that we prescribe are ketotifen, which is a very weak type 1 antihistamine, but it's a very good mast cell stabilizer. And people start off with 1/2 ml at night because it makes you sleepy. And then they go up, as they feel their body's getting used to it, they go up to another 1/2 ml until they're on 5 mils, which is 1 milligram at night. And for some, that is an absolute game changer. For others, it doesn't work at all, or they don't get on with it for some reason. And then there's rupatadine, which is a tablet, 10 milligrams once a day. And again, for some, that will be really helpful, and for some, it won't. So you don't do both rupatadine and ketotifen, you do one or the other. And then if that doesn't work, you try the other one. If the symptoms are predominantly in the gut, we suggest sodium chromoglycate. Now, sodium chromoglycate is a very good mast cell stabilizer for the gut. It's not absorbed systemically. Only 4% of it is absorbed systemically. The rest stays in the lumen of the gut. But as the mast cells are lining, just under the lining of the gut, they will be affected by it. So often patients who have got IBS type symptoms, that cluster of symptoms affecting the gut, will have tenderness across their epigastrium.
The top of
and sometimes, for the transverse colon. And there's a lot of mast cells there. And they get tenderness and bloating. And if you give them the sodium chromoglycate, you can they're like, oh, it's not hurting anymore. I'm not bloated anymore. Fantastic. Doesn't work in everybody, but again,
when you find what works, so this is a really dramatic benefit to these patients.
Yes, absolutely. It can be very dramatic. And it's very rewarding to actually be able to pull this together for people and to be able to say, I think there's a pretty good chance that we're talking about your mast cells that are overactive. I think these are the triggers. Let's try this. What do you think? And do it in conjunction, obviously, discussion with the patient. And often they have light bulb moments and go, you're absolutely right. That is me. And then they get some symptom relief, which is great. So there's usually a cocktail that we can put together for each patient, which will help them. Doesn't mean they're going to be on it forever, because once their mast cells start to settle down, they can manage their symptoms, they can manage their condition much better. They might go on to these things intermittently when they know they're going to eat out and will eat some things that are not so good. There is a group of patients, though, who just have become super sensitive to almost everything, and they can take longer to help. And the problem is the mast cells can last 2 to 4 years.
Does it? A mast cell lives for 2 to 4 years?
Can do. Some are replaced within 6 months, but if you're going to replace all of them, it could be 2 to 4 years. So you have to be very patient. Wow. Because how I always imagine it is that if you've got mast cells that have been constantly overactive, and new mast cells come into that environment where the histamine is high and the cytokines are high, they also become a bit sort of edgy and jumpy.
It's almost like an epigenetic effect, isn't it? The way that mast cell's programmed.
Exactly. And if you can calm the system down, then the new ones that are coming and being made will be in a calmer environment, and they will just be a little bit less edgy. And so you can gradually move towards everything being calmer. And certainly that's what happened with my daughter. She then became really, we had to work on it though, and she had to work on it really hard. And we actually did her genetics.
So how is Jessie now?
She's very pregnant.
Okay, well.
She's about to have her second child.
Can be pretty wonderful for a gran.
Absolutely fantastic. Yeah, best news ever. So yeah,
and Jen, she's okay. She's
well. It's interesting. She, after her first pregnancy, she felt like her immune system had been reset, and it wasn't nearly so sensitive. There are certain things that will trigger not just infection. Okay, so the mast cells, not just infection. you have to be careful that you don't put everything down to mast cells and you miss things. So you mustn't miss things like, which can be concurrent and adding to it, like chronic inflammatory response syndrome from mold. And so many people in this country have, we have quite damp
just
housing
breathing
stock.
in the mycelium.
Yes, and they will have mycotoxins, and that will trigger their mast cells and cause something called CIRS, which is, if you read about CIRS, all the symptoms look just like mast cell activation. So when I have a patient, when we're talking about their symptoms, we want to know all about, their history, but I also want to know, have they ever been exposed to mold? Have they ever lived somewhere that's damp? And so many students, it's heartbreaking, say, yes, my student digs were really moldy and there was black mold behind my bed. And oh dear, oh dear. So all these things are really bad news. Ticks, Lyme disease is another one that can give very similar symptoms. And the Epstein-Barr virus can be reactivated in some people and give similar symptoms, the chronic fatigue, etc., etc. So you've got to make sure that you're not missing any of those that need some help. And then, so we do that. And
it's so interesting. So when I used to teach anaphylaxis, I used to teach all the intravenous therapy, and of course the anaphylaxis lesson was standard. And I always said, within the first hour or two of an anaphylactic reaction, make sure you get a blood cell for mast cell tryptase.
Oh, yes.
So
okay.
I think we better talk about mast cell tryptase and the consensus 1 and the consensus 2 guidelines.
Yeah. Yes. So in 2012, a statement was made, and it was called consensus statement. And it was put together by some of the people who've been working in this field. And in that statement, they said that the serum tryptase needed to be elevated to diagnose mast cell activation
syndrome. This is basically, the tryptase is an enzyme that's released from the mast cells.
Absolutely. Yeah. And they said it needed to be elevated to prove somebody's got MCAS or diagnose them with MCAS. And they presented it as consensus statement. And that, meanwhile, a year before, a different statement had been made by about 40 of the researchers and doctors working in this field, who had made a broader definition because based on what they were seeing in patients. And they said they weren't so prescriptive with their consensus statement. So they called the consensus statement 1, and theirs consensus statement 2, to differentiate between the two. And in consensus statement 2, it says that because it is in some parts of the world difficult to get lab tests done to help with the diagnosis, and that certainly was the case until very recently in the UK, and because the serum tryptase can very often, much more often than not, be normal in patients with typical mast cell activation symptoms and patterns and history, it's not helpful to rely on the serum tryptase. So in this group, this subgroup, if you like, and I think both statements probably have their place and are helpful, but the first statement, consensus statement, excludes so many people with this condition who then don't get a diagnosis and don't get treatment and helped. Whereas the other consensus statement 2 is more all-encompassing, so it actually helps.
It's more of a clinical diagnosis, really, a clinical picture diagnosis.
Absolutely. It's a clinical diagnosis, and you do recognise the patterns and you see it, and then you say, we suspect it. Let's try treating, and let's see how we go. And lo and behold, they get better.
I think that's the diagnostic feature then, really, isn't it? It's the fact that the particular treatment that you would expect to treat the mast cell activation syndrome does, and that really helps your diagnosis. If you've got a pain in your finger and there's a splinter there, and you pull the splinter out and the pain goes away, it's a good indication that the splinter was causing the pain. It's
absolutely. And the consensus statement 1 doesn't seem to recognise how common mast cell activation syndrome is. And whereas Professor Molderings from Bonn, he's done the research there, and it's 17 to 20% of the population. So, and that would fit with what we see, you know, with your real world experience, clinical experience. That would fit with what
different
we see.
levels of severity, though, presumably.
Yeah, totally. It will depend on which combination of genetic variations they've got. And you know, and some poor people are just sensitive to everything. They can't even take any vitamins and minerals. You know, there might be an excipient in a drug or in a supplement that they can't tolerate, and they will have a big serious reaction, like an anaphylactic type reaction to something. I mean, some people can be that bad. And I have got lots of patients who have been, you know, very, very severely ill, but now they are very much better. We've managed to very slowly, very patiently calm things down. And there are certain things like low dose naltrexone that can be really amazing. Very tiny doses of LDN seem very, very anti-inflammatory. And that can transform people's lives. It doesn't work in everybody, but when it does work, it really is very compelling, you know, amazing stuff. Also, I'm using a lot now of mycotherapy. Medicinal mushrooms are very immunoregulatory, and they can calm mast cells down. So there's some, we've had some very, very good results with those with patients.
I want to come on to, well, there's a lot of things I'd like to come on to. It depends how long you want to stay with us. Can I just issue a bit of a challenge, though? How can mast cells degranulate and not release tryptase?
I'm not sure.
Or is the tryptase metabolized more quickly in some people?
I don't know how quickly tryptase is metabolized, but I do know that a lot of the cytokines are released in very tiny, tiny amounts, which possibly wouldn't be very detectable. And they are metabolized very quickly away. So they're sort of they're a bit hit and run, you know. They're there, they create havoc and chaos, and then they're gone, but the chaos remains.
I'm sure we all know people like that.
So yes. And they probably have no idea that they're doing it. And so it's actually very, very difficult. And I don't think tryptase is, I think if you've got different genetic
it's reasonable to postulate that some people are quick tryptase metabolizers and some people are slow tryptase metabolizers.
And also that some people don't release tryptase. You know, and in mastocytosis, which is quite different, mastocytosis is very rare, and it's neoplasm of the mast cells. Okay, it's genetic. It can be cutaneous with skin lesions. It can be systemic. When they have systemic symptoms, the symptoms are exactly like mast cell activation syndrome, because it's the same thing. But in mastocytosis, there are excess numbers of abnormal mast cells. And there are so many of them, they do release tryptase, and the tryptase will be elevated, but really elevated. So, you know, I have got some patients who've got mastocytosis. I've got two, and they respond incredibly well to the same treatment that the MCAS patients do. So they go to see the immunologist who examines their skin and does a thorough job of all of that, and is fantastic at keeping an eye on that. But they come to me for the type 1 antihistamine, type 2 antihistamine, maybe some LDN, etc., and they're so much better.
It really is quite impressive. I think we'll probably leave that there for today, Tina. There's so many things I want to ask you about, but we're on an hour and 7 minutes already. So maybe just tell us a little bit about the mycotherapy. I'm so curious. What mushrooms are you using?
Okay, so you've got to use very good quality mushrooms. That's first of all. And mushrooms per se are very high in histamine, but there are various chemicals within the mushrooms that can be extracted without bringing the histamine bit as well. And they, so particularly the sunshine mushroom is a mast cell stabilizer. And it reduces histamine and cytokine release. I'm
not familiar with it. Is it just another edible mushroom?
It's just, I mean, there are hundreds and hundreds of, there are thousands of different mushrooms.
Do not go and pick mushrooms in the wild. Only get them from an expert. We don't want anyone dying of mushroom poisoning after watching this video.
No way. And then the other one I like to use. So I use a company. Am I allowed to say the company's name? Yeah, okay. Hifastatera is a Spanish company. I really like them. They've been going for 25 years. Everything is organic. Everything is tested. There's no fillers. It's absolutely pure, active ingredient. And they test every single batch before they let them go to make sure they haven't got any pesticides or insecticides in the soil that they've been growing them in. They grow their own. They also do research in patient groups to prove that it does what they say it can do. So there's lots of clinical data behind all of the claims. So I like patients to use one called Mycosol, which is the sunshine mushroom, and Myco 5. And Myco 5 has got 5 different mushrooms in it. So you get a very good deal with that one. You get the sunshine mushroom, you get reishi mushroom, and the reishi mushroom, what does that do? That balances hormones.
Lower anxiety levels, can't it?
Yeah, absolutely. Helps, makes you feel more relaxed, a little bit more chilled out, helps improve sleep. It's also got anti-inflammatory properties, and it has analgesic properties. And then there's the chaga is in there, and chaga helps cancer cells to apoptosis, basically. I always describe it as
cell suicide.
Absolutely. Cell suicide is pressed by chaga if the cells are abnormal. So that's been used now in some studies to help as an adjuvant for cancer treatments. And then there's 2, shiitake and maitake, and I can't remember which one of them, but one of them treats mycotoxins. So if somebody has been exposed to, even as a child, to mold, they will still probably have the mycotoxins in their body, and taking the Myco 5 can really help clear it out. So it's a really, and people can feel it, John, honestly. They take it, and sometimes even by 10 days, sometimes 2 weeks, sometimes 6 weeks, but mostly people are saying, I feel more balanced. I can feel my body isn't so reactive. So I much prefer to use natural things if possible, and things that people can source for themselves and don't rely on prescriptions and so on. So, if we can get them balanced. And I find that if people take those, then often they don't need to take some of the other things that they were, some of the other medications.
And there's no doubt that various sorts of mycotherapy, various mushrooms, I mean, there's so many amazing functional properties of so many different mushrooms. This is going to be a huge thing in the future. The problem is, of course, that you can't patent mushrooms, so Big Pharma aren't doing a lot of the research, unfortunately. But what we really need is a lot of more people to start growing mushrooms, because they're really good for you anyway. The microbiome, various nutrients, and I think we talked briefly about lion's mane mushroom, which the Chinese call monkey head mushroom, because it's like got like it's like shaggy like a lion's mane, and that has properties which do cross the blood-brain barrier. And there are chemicals in there which do stimulate nerve growth cytokines. It really is quite incredible. And then, of course, there's the whole Professor David Nutt thinking on psilocybin and other things like that, which have got. And I have talked to psychiatrists that are starting to use psilocybin actually. So a whole new field of medicine there coming. But I really would be really nice to get more people grow mushrooms locally. I've been trying to encourage a few people locally to start just growing them, and the legal ones, of course. We wouldn't not dream of telling anyone to grow Class A drugs, but more to come on that story, I am sure. Tina, that was just fascinating. My mind is awash with information here. I'm just sure there's going to be a lot of patients recognizing these symptoms in themselves. So if you do recognize it, do make a note of your symptoms, keep a diary of your symptoms, when they're good, when they're bad, the fluctuations, come up with this kind of pattern. And then when you go to your doctor, which you must do, of course, you've got a whole load of things ready to tell them, and if they're prepared to give you the time, then they can potentially make this diagnosis and start trying these things that would confirm the diagnosis. And there's just so many people that just are under the weather so much of the time. I'm not entirely satisfied with the way I feel most of the time, to tell you the truth. Sometimes you're anxious and sometimes your brain's not quite with it, and It's just the thing, I mean, a lot of it's lifestyle with me, of course, but it's the same with a lot of people. But if these specific pathologies that could be treated, it's just absolutely marvelous. Yeah, thank you. So good. At another time, what I'd like to talk about, this is just a teaser, if you decide you'd like to do it at some point. One thing that's really stood out for me there is the importance of taking a patient history. I'm don't want to talk about it now because we're well over time now. And just this whole philosophy of natural therapies is such an interesting one, and the way ahead. So many of the drugs we have at the moment, my British National Formulas, my bottom book there, but I've got a big red one there. It's very, very often drugs that have been through the clinical trial process that have often been sponsored by the pharmaceutical industry. There we go. Needed two hands. This one. So all the drugs that you can prescribe are in there, but these are, and of course, many of these drugs are absolutely wonderful and brilliant and life-saving. But you just get the impression there's so many more things like this lion's mane that can be so beneficial that we don't have ready access to, and it just seems a pity that there's this whole class of therapeutic lifestyles that we're not using at the moment. So a whole new field there. Mm-hmm.
If people are interested, John, in finding out more about mast cell activation syndrome, the big names are Dr. Lawrence Afrin, who's in New York, then Dr. Dempsey. She's very big. She works with him. Professor Molderings in Bonn University, and Weinstock, Dr. Weinstock. They've produced a lot of papers and case studies and doing research into it. I'm very, very fortunate because we have a group where we exchange ideas and questions and new bits of science all the time. And literally twice a day I get an email from this group. It's an international group, and it's getting bigger and bigger and bigger as more and more doctors and physicians, clinicians, nurses, nutritionists, dietitians, are getting to know about it and then applying it to their patients and seeing the successes and the improvements, and then want to know more. So it's a really great group. But Dr. Lawrence Afrin has got some very good presentations on YouTube. If you
can send us some links, Tina, we'll just put any links you send, we'll paste them, of course. Yeah.
Okay, great, good,
marvelous. Thank you so much for that. so interesting, and we can certainly talk about doing some other things if you'd like to. But that was really, really brilliant. Thank you so much.
It's a pleasure.